our
Allora, devo
policy,
dire che noi
I know
prendiamo in
other
diretta,
people
ok?
be interested to hear from the panel and the participants, is when do you think it's best to
Loro
close
già le
an
vedono?
ASD? Because then the septum gets bigger as the patient gets bigger, but not necessarily does the ASD get bigger. And we've waited a lot of times to the age of 5 or 6 for relatively larger ASDs, closed them with no problem afterwards. So why are we trying to evaluate kids at the age of 2.5 years?
I think this was an exception. We usually close the defects before school starts.
I went to
So
the
usually
GSO,
between 4 or 5 years. This was an exception because the child was suffering
yes, he
from
arrived.
this ASD, and we did this
Because it was
earlier.
the most,
But you're right.
it was
usually
nearby my
it's 5
house.
years. But there is at least one paper in the literature, you know, the paper from Texas Children following patients, and many of the patients that have been followed that initially were thought to be candidate for ASD, after the follow-up they became not candidate because the ASD definitely got bigger.
Oh yeah, I agree. I mean,
So
obviously that can happen.
I think personally, if you have a child that you can put a catheter in their groin safely and easily, I think even if they are 10 months, 11 months, I would not hesitate to take them to the cath lab. You know, granted you need an indication. If they're totally asymptomatic, I say, you know, wait, but some of these patients, they have failure to thrive, repeat infections. So those are the patients that bring them irrespective of their age and weight.
Parallel to the septum,
do you
go
find
parallel
that
to the septum, but it's very
you
difficult to
obviously
go
have no
parallel to the
complications,
septum,
but
the ASD.
in general, I mean, is it worth the risk because you have ECG complications, you have a higher risk of perforation,
No, there is no higher risk of perforation.
you have less atrial compliance goes down because you have a big device in a small heart.
No, I think, you know, the incidence, and what we published in that, the incidence of complication is similar to the older patients. Let's have some questions from the floor here. Go ahead.
You have 2 people.
Can you please walk on the microphone?
Yeah, Shaka Reshi, Evelina Children's Hospital, London. This is a very important point, isn't it, about what stage do you, how early do you close atrial septal defects? Now, the problem is that if you follow the traditional line, which is we used to wait, certainly in the UK and perhaps in Europe, up to 4 or 5 years of age, quite a significant number of ASDs would become small enough not to require closure at all. So you might start with a 10 millimeter ASD, which by 4 years, 5 years of age was 5 millimeters, and you didn't close it. If you close them by catheter techniques, and people have started closing them earlier, once the catheter techniques became available, if you close them without any complications, then you could probably justify closure at 10 kilograms or whatever.
Great.
The problem arises when there is a complication, and there are complications around the world where within that sort of 8 or 10 kilo child, a device is embolized, it has become very difficult to retrieve. The child has had surgery, has suffered neurological damage, and it becomes very difficult to justify closing a small to medium-sized ASD in a 10-kilogram child. So I think it's a very important point for us to be aware of, rather than saying, yes, those ASDs
Great.
become big.
We're going to cut this story here. We're going to go live to San Donato with Massimo. Hi, Massimo.
Hi everybody.
Good morning.
Can you hear us?
We can hear you and see you. I have on the podium with me Dr. Elkanan Bruckheimer, and on my left Dr. Marco Papa, and entire room full of people from all over. The microphone is yours. Go ahead.
Good morning and welcome. It's a great pleasure for me to start this live case session, and it's my great pleasure to work this morning with a great staff. You may see Dr. Andreas Aiken that joined us, great pleasure. Dr. Luca Junior, our senior registrar, and on my back, all technicians and nurses and the anesthesists working with us today. Very important, the ECHO team, Angelo, Antonio, Savi, working with us to get a very nice picture for you. So please, Angelo, can you introduce the patient?
Yes. Okay, good morning to everybody. This is the first live case from San Donato. This is a 74-year-old woman, a little bit overweight, with a long history of systemic hypertension on therapy. She was recently admitted for an episode of atrial tachycardia, and during the admission, the echocardiogram showed some degree of pulmonary hypertension, less than half systemic, dilatation of the right-sided heart, and there was the suspicion of a large secundum ASD. This is the chest X-ray showing some vascular, increased some vascular markings and some degree of cardiomegaly. And the suspicion of atrial septal defect was confirmed by a transesophageal echo, and you can see here some picture with a large secundum ASD. So she is now admitted to our hospital, and we decided to do a complete workup with cardiac catheterization in order to assess all the pressure and the resistance and to see whether or not she's suitable for an ASD closure.
Okay, maybe Angelo, may you show some picture, some live picture? Echo, please. You make a comment on that.
So we have some 2D explained picture. You can appreciate a floppy septum with a floppy primum septum. Go on. And this is with the color, with a quite large secundum ASD and deficiency of the aortic rim. In the bicaval view, still the defect at the level of the fossa valis.
Can you show us the classic short axis view, the aortic valve, so just to see the retroaortic rim?
Yes.
At 15 to 30 degrees, this is not the short axis. Yeah, there you go. 15, there you go. So you can see, guys, the retroaortic rim is very deficient.
Yeah.
Let me turn the lights on for a second. I'm going to ask the audience here who would close this in the cath lab versus open heart surgery. Can I have the rooms on in the room, please? Somebody in Italian? Marco, ask them to turn the lights on. Turn the lights on so that we can see. Potete accendere le luci per... All the room.
In tutta la sala. Possiamo avere le luci alzate in tutta la sala, per favore? Possiamo avere le luci in sala, per favore, per vedere chi vuole parlare dall'audience?
We're going to do a primitive audio response system. Everybody's asleep. Well, they're not responding. All right, Massimo.
Okay.
Go ahead. Continue.
Okay, so we have here a young lady with the old history of systemic hypertension, large ASD, maybe a history of pulmonary hypertension. So what do you want to know about this patient? What do you suggest to check at the moment? Would you like to get more information or what?
Well, what's the hemodynamics? I mean, does she have pulmonary hypertension or shunt size, standard stuff?
Okay. We did a complete assessment. Maybe we can show the slide, please, of the patient.
Yeah, show the physio monitor with all the numbers.
The last one? Yes. So we just did it.
Yes, so the mean PA pressure was 27, mean LA 21, so that's a red flag right there.
Yep.
QPQ is 2 to 1, PVR is 1. So from the numbers on the screen, Massimo, what was your next step?
So first of all, we decided that the pulmonary hypertension was not so important. Actually, we don't care about it. So we decided don't get anything more from pulmonary hypertension assessment.
Correct.
And what we decide to do is to do a balloon occlusion test, just to see how the telediastolic and left atrial pressure will change during and then complete occlusion of the defect. Maybe Andreas, can you make a comment on that?
We saw, good morning everyone, we saw in the TEE that the mitral valve was mildly regurgitant, but there was good left ventricular function. Maybe you can show that?
Here we have mitral.
Yes.
So that's mild MR.
Yeah.
And it didn't really change after test occlusion of the ASD. But
how about the LA pressure?
But the end diastolic pressure in the left ventricle went up.
How high?
To 28.
So from a baseline of 21 to a baseline of 28 during balloon occlusion of the ASD. Now let me ask a question of the audience. Those of you who believe with this hemodynamic the patient should proceed to have complete device closure of the ASD, raise your hands. Okay. Those who believe the patient should not have device closure of the ASD, maybe with a special device, fenestrated device, raise your hands. I think it's 50-50, guys.
So close half of it.
50-50. People will say close with a conventional device, other 50 with a fenestrated device. So now it's your choice.
Yes.
Massimo.
Yes, we had a discussion with the staff here, waiting for to get online. And, actually, in our experience, we saw in a couple of times, a couple of cases, pulmonary edema after closure, complete closure in such kind of patient. For that reason, we prefer to create a small fenestration into the device and to close the defect using a homemade fenestrated device. We discussed with Andreas and we agree at that point. Not you?
Yes.
So what you suggest? To create a fenestration or not?
I personally would agree with you. I think with an LA pressure that went up to about 28, 30, I would feel, and she was on medications, this patient, so it's not that I'm going to take her back, retreat. She is already on medications. I think the wisest thing is to leave a small fenestration and take it from there. If the fenestration is not being used, it will close on its own.
Okay. Yes, that's what
We have a question from the floor, Dr. Dalvi. Microphones are up, please, on the sides, please.
Coronarography, patient. Coronarography.
Yes, we did it. The coronary are pretty fine.
Good question.
Yes.
Yeah, I just...
Come to that microphone.
No, one comment I wanted to make was regarding how reliable is the balloon occlusion test vis-a-vis the actual device closure. The reason to ask you this question is because when you put the balloon across the interatrial septum, you close the defect completely acutely. As against that, when you put a device, there is always a residual shunt. And there have been n number of cases where balloon occlusion shows increase in the pressures. When you put the device, the pressures are never elevated to that extent. And the second is, because the balloon occludes or occupies a space within the left atrium, you may have sometimes erroneous increase in the wedge pressures. So these are the two comments I wanted to make. So why not try with an ordinary device, and if you feel that the pressures are looking good, you can close it completely or else come back with a fenestration.
No, I agree with you. One second. I agree with you on the volume issue. But the other thing that you have to remember is the patient is lying anesthetized on the table, and you don't know what happens when she does stress. Like when she moves, the pressure may go up, the pressure may go down. So everything is ballpark, and that's why I think that if you have something which truly changes from 21, the baseline is high, 28 is even higher, and nowadays there are two companies at least which are making left atrial decompression devices. There's V-Wave and there's DCD devices for congestive heart failure to reduce the left atrial pressure acutely. So I think that going for a fenestration, irrelevant of what the absolute findings in the cath lab are, is very, very important in this patient, because when she gets up, if she doesn't do well, we're going to send her to open heart surgery to fenestrate her.
Okay.
I think the most important thing in this patient is to put this patient on the diuretics before close. I think it's very, very important to do that.
She was on diuretics, no? She was on diuretics before.
Yes, absolutely.
She was on diuretics.
Some more comment on question?
Should we move along?
Okay.
Go ahead, Massimo.
Okay. So we get all the points from the audience. That's the reason why this patient is here, because we believe that this kind of patient are very difficult patient to treat and to make decision. But what we observe in our experience, that people that had such a response during the test occlusion or the balloon test occlusion are doing pretty well. The only patient we get into troubles are patients where the story of the diastolic dysfunction was not very well managed before to close it. But in all patients we treated at the moment, the 6-minute walking test, the cardiopulmonary test that you usually do after 6 months closure, 12 months closure, show that the patients are doing very well. That's the reason why we are more comfortable now. So the idea is, first of all, can you show this, the balloon sizing? So you may see, Andrew, please. Okay, this was the balloon sizing. It was 32.1. In another measurement, it was 32.4. So what do you suggest in terms of the diameter of the device?
So let me ask you, Massimo, by 2D echo, TEE, what was the anatomical size of the defect?
Angelo?
23 millimeter.
How much?
23.
30, no, 23. Not the balloon, the 2D
no, the 2D
dimension.
Yeah, the 2D was 23, 25. When at the really beginning, where we put the stiff guide wire, the diameter increased till 26 because of some tissue. You may see the picture. Can you show the echo picture, please?
Can we see the image? Yeah, so that diameter is how much? 23.8.
Yes.
20, that's the largest diameter.
Yes.
And you stretched it to 33, so that's 10 millimeter divided by 23 millimeter, that's almost 48%. Because the reason I'm talking about this, because we are comparing the oversizing to the initial phase 1 trial data with the Amplazol. Any device which was not oversized by more than 50%, those initial cohort of 450 patients never had erosion. So here you are just around that number. So what device are you going to take now?
So what do you suggest?
Well, if you tell me that the balloon is 33, then obviously I'll go with either 32 or 34 millimeter maximum.
Yes, we decided.
But I'm looking at, you know, if I do that, what percent oversizing from the 2D echo? So let's say that you took 34 millimeter and your defect is 23.8, let's say it's 24 millimeter, so that's 10 millimeter divided by 24, so that's about how much? Yeah, 40, yeah, almost. So you are at the edge of safety there. I would prefer it to be smaller, like 32 or 30 millimeter if possible, but obviously you are the operator there and you have to decide on the size that you want.
Massimo, was that a stop flow measurement or was that a stretch measurement?
No,
because
we did
it's a very floppy septum.
Yes, with a floppy septum, we prefer a stop flow. Otherwise, we get a larger hole. So we did a stop flow in this case.
Okay. Shaq, you have a question?
Just a quick hypothetical comment, really, and that is, if I was not doing balloon sizing as a routine, I don't, I would have relied on the echo measurements, and in this case, I wouldn't have gone above 30 millimeter device. So now the balloon test has probably muddied the waters a little bit, You've got a good weight on that, so the likelihood is with stop flow it's going to be about 30. So I would be looking at 30 with the fenestration in this.
Yep.
Okay.
Sorry, could you tell me the size of the anterior septum? Did you measure it? What's the question? The size of the septum, not of the whole of the septum. Why the size of the septum is important for you?
So,
yeah, because of the size of the umbrella. I mean, if you choose a 30mm umbrella, you will end up with a 40. But this is an adult size. You're going to open an umbrella in the LA. If it opens, it fits. If it does not, it does not fit.
I mean, it's
measuring the length of the septum, as you know, Martin, by echo, is a flawed with a lot of error. I mean, look at these measurements. He's measuring from one end to the other. That's not accurate. So he measured how much? 48mm.
Yes.
Okay.
That's one dimension only.
Yeah.
So I'm going to ask also a question to the audience. Those of you who believe should close with a device 32mm, raise your hand.
You need light?
Okay. Those who believe should use 34mm, raise your hand. Less? Okay, let's go back the other direction. Those of you who should use 30mm. So Massimo, just to let you know, the audience poll would prefer either you use a 30 or a 32mm device. The opinion is a split, 50-50.
So actually we decided for a 32mm.
32? So
yes.
That's good. Half the audience is happy.
Okay. I can make everything happy. So I'm happy with the 15%. So can I have the 32mm device, please? May we open it?
Is this the fenestrated device, Massimo?
No, we're going to fenestrate it.
You don't have the fenestrated device on the shelf?
No, we are going to do an homemade fenestration.
Okay. I thought in Europe you guys are more advanced and you have them on the shelf. Unlike the US, we have to do our own stuff.
May we show my hands? So I prefer to start with a needle, just to create a small hole. I put a guide wire, just a long one.
Okay. There's a paper published on this years ago to show you the technique for this device as well as for the Gore septal occluder, how to fenestrate these devices.
May I have a dilator,
and
please?
how to deploy it.
I'm very happy because Andrea is helping me. Thank you, Andrea.
Sure.
Okay. So we create a small hole with dilator. Then
what dilator size is this?
Is a 10.
10. So I assume we're going to go to 11. Because the 11mm, 11 French dilator gives you about almost 5mm fenestration.
And now I will use, Ziad, if you agree, I will use also a balloon, just to stretch a little bit the small hole.
Yep. See, the problem, you're dealing with nitinol that has self-memory, so no matter what you do, you're not going to be able to, affect the nitinol wires at all. Just the patch. That's how we're going to affect the patch.
Yes. So it's a 12mm balloon. So we inflate it. You may see that. Okay.
Yep.
Okay. Deflate. So I think we have a nice small hole. You may see it. You can zoom. Okay. You see?
No. Yes. Beautiful fenestration.
Okay. Then we download the device. So just ask me a question to to the audience. Are you going to create some system? Or do you suggest to create a system to save the position of the device, like a snare, in order to release the device, but to be sure if retrieve if you are not happy with the device? Because it's a big device, deficient rim, some floppy tissue. What do you suggest?
So what we have done in our lab using this technology is, of course, have a guide wire in the left upper pulmonary vein. When this guide wire comes out of the sheath, then the guide wire will put it through the fenestration that was created, so that you will know that this fenestration is aligned and it's within the ASD proper. When you have the, and then of course you can load the device, the guide wire, all into the delivery sheath and then proceed with that. So you will see now when he starts deploying the device.
Okay, we discussed with Andreas, the idea was to use a snare in order to fix the device. Once released, we still will have the possibility to retrieve it if we are not happy, or to have the possibility also to stay in touch with the device if in case of embolization. So the idea was to put a 5mm snare just on the top here to download the device now.
Okay. Can I just, one thing, is it worthwhile in this patient, since we've had a debate whether to close, not to close, and fenestrate, just to do 2 fenestrations, and then you'll also be certain that at least one of them will work, and if 2 of them work, you'll still have a very significant reduction in volume load. And they're likely to close anyway, and she won't be able to increase stroke risk. So I personally do 2 fenestrations, and then you'll solve all those issues. Jim Franco.
Question there?
Okay. More? Okay.
I fix it?
Yes. So
we can't hear you.
So we are ready to download the device with the snare. You see here, we fixed the device with the cable, also with the snare. Okay.
I have a comment on what Ziad said, Gianfranco from San Donato. The possibility to have the guide wire through the hole makes you give you another option. You may recheck end-diastolic pressures and redilate or dilate a bit. It happened to me two times, so it can be very useful.
That's why we do it, yep.
Okay, let's go with a 12mm long sheet.
When is it now?
So can you show the table now? Okay, perfect. Fix the guide wire. Thank you. Okay. So I remove the dilator and the guide wire as well. Okay. May we get the device, please?
Yes, Chef.
One quick technical point is in the presence of or absence of aortic rim, whether you would start deployment in the right upper pulmonary vein right at the beginning rather than stay in the left atrium or left pulmonary vein.
But he can't do this. I think, you know, with the guide wire in the sheath in the left upper pulmonary vein, he has to deploy near the left upper pulmonary vein and come back, not the right.
But the guide wire is out now, so you can rotate the sheath.
And now I can cut.
But then you will have a lot of torsion. You'll see when he, Leuven is ready at 9:15.
Devo fare tu, così tengo qua perché sennò. Ok.
People is not finished yet. Then
okay, just a second.
Massimo,
yes.
Which size is the long sheet?
Is a 12 French, sorry.
Okay. Don't you exceed a little bit when you have a snare?
Actually, 12 is perfect.
Okay.
You don't need to exert more than 12. Okay. We are just cutting the loader. Okay. Perfect.
Ziad?
Yes.
I have a comment on that. As Massimo knows, we are using this technique since several years, and we have collected a series of 25 cases. If you use a 5mm gooseneck snare, you may go through a 12 French sheet. Otherwise, you cannot go down than the 12 French sheet.
Yes. Great. Bharat?
So I will start to deploy the right disc. May I have a normal, okay?
Let's have picture-in-picture TEE and the fluoro.
Ziad, I wanted to ask two questions about fenestration. Do we have any standardized protocol as to the size of fenestration, whether we make 1 or 2, but whether we are going to make 4 millimeters, 6 millimeters?
Just 1 second, let's see the, and then you can ask. 1 second, Bharat.
So you see the shape of the left disc, and now I'm just approaching a little bit the septum. We may try to open.
He doesn't have the wire through it.
Okay?
Yes.
Can you show? Very good. Okay, I think the positioning looks good. Can you show, yes, the picture, echo picture, thanks.
There's the fenestration.
No, it just looks like a leak.
I think the position is good. It's good.
That's just a leak.
You're going to see it in short axis.
May you make comment on that, Angelo?
Can you show us the fenestration? That one.
I think it is the fenestration. You just saw it. That one. So maybe I just do a small Minnesota maneuver to be sure that it's stable.
See, the technique that he used is somewhat different than the technique that we discussed, where he would have, pass a wire, which he did not pass a wire, through the fenestration to make sure that the fenestration remains in the center of the ASD.
Yes, that was a good suggestion. I didn't follow you.
With this technique, I cannot be sure that the fenestration is indeed is in the middle of the ASD.
Okay. Maybe we may release it. I don't think we have to do anything more here. You just have to start to release the device. Yeah. Okay.
And the advantage of having the wire through the fenestration, you can always put a small guide wire through it to the LA to measure left atrial pressure when you deploy the device. So now, obviously, we cannot do that.
Yes, we can measure the telediastolic pressure if we need it.
Bharat, what's your question, comment?
My question was that do we have any standardized protocol as to what kind of fenestrations we make, 4 millimeters, 6 millimeters, and whether there is been a serial follow-up of these fenestrations? Do they actually last 24 hours, 48 hours, 1 month? I mean, or it is just a sense of security to the operator that I have made a fenestration. So, because the best thing would be, in my opinion, put a device without a fenestration, do the hemodynamics, create a fenestration, do the hemodynamics, and see whether there is a real difference, because all these devices have some amount of foaming and some amount of decompression occurring all the time.
So you propose put a device completely, close the ASD,
and do the hemodynamics.
Okay.
Then make your fenestration the way you make, and put that device again, and see whether there has been any change in the hemodynamics. Because if there is no change with a 4 millimeter fenestration, I think this exercise is an exercise in futility.
Yeah, we do 6 millimeter fenestration, Bharat, and we have been following the few patients that we did, up to 5 years of follow-up. The patient that at least I had that, he had his fenestration closed on its own.
Ziad?
After 5 years. But this yes, Massimo.
Yes, we released the device, as you probably saw. We still have the snare, so the position is now the final position. We may see some flow through the device. It's probably the fenestration. Angelo, can you show that? We are going to release now.
Okay.
Okay.
Before you release, what's the LV end diastolic pressure?
So let's check. Can you put a guide wire into the pigtail, please? I cannot do that alone. Okay.
And also, whilst you're doing that, Occlutech make a sort of proper fenestrated device, Z, and that can be 6 or 8 millimeters, and those are more predictable in terms of duration of patency.
Yeah, because those were designed from the manufacturer, so it is a real fenestration. Do you want to go to the LV, Massimo, to...
Yes, we are going to LV now.
There you go. Come back with the wire.
Your position. Yes. This one, yeah. You may flash, please. Ce le lavate? Ce lavate la via, ragazzi? No, l'altra.
By 3D echo, the echocardiographer, can you see the fenestration?
We are trying to see, and from the right side, it seems to be a hole there where you can see the
Vediamo il ventricolo sinistro, ragazzi.
May we have it in the large screen, please?
She's losing a lot of...
Yeah.
It's probably there.
And is there a way to turn color Doppler on the 3D to see if it goes through it?
We'll put the color.
Yeah. Is this Dietmar? Dietmar, yes?
Very nice presentation, but as Ziad has mentioned before, if you have now a wire in the fenestration, then you have the option even to stent the fenestration, because I never have had the luck that this fenestration will be open, but by stenting the fenestration later on, because it's very easy if you have a wire in to stent it as a fenestration, you have a good long-term effect as a fenestration. And I think this patient with this restrictive physiology needs a fenestration. In the last year, 2014, I opened 3 ASDs again when they was closed, because they was ended at the ECMO. So I think the patient would have a good benefit if he have a fenestration of 6-8 millimeters. I think it's my comment. Thank you.
Thank you.
Thank you for your comment.
A comment to Dietmar's comment. Sometimes this patient may improve their own diastolic dysfunction. So in my experience, there are fenestrations that may close spontaneously. Yes, so why not having this possibility to have the fenestration closed spontaneously?
Gianfranco,
because
we are releasing the... We need to release that, okay? Because it's... Okay? You see that? Okay? Okay. And store floor, please. Yes. So, back to the echo now.
So what was the EDP?
What is interesting regarding now the telediastolic pressure of the left ventricle, it reached no more than 20 at the moment.
20 is high.
But it was 20 at the beginning of the story. So I'm pretty sure that it's going to do very well. I'm pretty sure. Because in our experience, we don't get into troubles with this kind of patient when the story is like this one. So I'm pretty sure. Okay, any more comments? Can you show maybe the 3D? Yeah. Andreas, any comment at the end?
No, I think it's a good position, and I think it's okay like this.
Okay. Do you usually fenestrate devices? You put the guide wire into the fenestration?
I think it was a good idea to do it in this case, although we don't really see the flow now. I think it was a good policy to do it in this case, the way you did it.
So Massimo, do you want to wrap up the case and tell us what's the take-home message now?
The take-home message is probably, I don't know if Helmut Baumgartner is in the audience, but probably the final message is that we can close ASDs in elderly patients because they feel better. There is a change in terms of quality of life and also perception of life, of quality of life. I think it's very important in an old patient, this aspect. Usually what we observe in this kind of patient is a change in the 6-minute walking test. They are not able to walk more than 218, 300 meters, and 6 months, 12 months after they reach 315, 400 meters. I think it's a good achievement for a 74, 75, 76-old patient. So is the take-home message?
You know, I was going to ask you a question, Massimo, and nobody asked the question here before. From the history, this patient has atrial fibrillation.
Yep.
Atrial tachycardia.
Atrial tachycardia, yes.
The question is, of course, what did the electrophysiologist say before you brought him to closure? Did the electrophysiologist say, well, let me go and map and see if I ablate, or go ahead and close it and forget these atrial tachycardia issues?
Yeah, we had a long discussion with our electrophysiological team during the last days, preparing the case. And the final decision was that she just had atrial tachycardia, one documented run. For that reason, she was on therapy for that. Because of the CHA2DS2-VASc was 4, she also was in anticoagulation therapy. And they decided don't do any map, any cart for this patient. The other question that arises during the discussion is what about the left atrial appendage? Because we are managing a patient 74-year-old, maybe at some point anticoagulation therapy may become contraindicated. But the discussion was that the electrophysiology are usually able to cross also the septum with the device inside, if necessary, to close the left atrial appendage. So there was a long discussion with the
So let me ask the audience then, with a raise of hand, if this is your patient and you want to close the ASD, those of you who would close the appendage first and then the ASD, please raise your hands. Because the rest does not know how to do left atrial appendage closure? No indication.
No indication.
There's no indication.
Exactly.
She has atrial tachycardia and she CHA2DS2 score was a 3 and she's an anticoagulant and there's no indication.
She's had one episode of documented atrial tachycardia, not atrial fibrillation.
Atrial tachycardia.
There's no contraindication.
But CHA2DS2 score is high.
Yeah, but the CHA2DS2 score is high because of her diabetes, her hypertension, etc.
That's why she's high risk.
Yeah, sure, but those are by closing the left atrial appendage, you're not going to cut the risks of diabetes and hypertension. So unless she has got either paroxysmal or established atrial fibrillation, I don't think there is a contraindication. There's an indication to close the left atrial appendage, and there is no contraindication to her being on warfarin.
Yes.
Can we pull the guidelines, guys, the ESC guidelines for appendage closure?
Well, and I think that not just in Europe. I think also in the States, you would not have a clear indication for left atrial appendage occlusion, even though Watchman has now been granted FDA approval.
Yes, it was.
All right. One episode of atrial tachycardia, you wouldn't close left atrial appendage, no matter how old the patient is, would you?
No.
This is one episode that we know of, my friend. And
yeah,
she's 74.
presumably she's been monitored from whenever she presents.
74, I can tell you, the older she gets, the more atrial fibrillation she's going to get.
We don't have any evidence of that. You can't be closing appendages on the basis that she's going to get something in the future.
I would not be closing appendage if she was not undergoing closure of ASD.
Yeah.
You know, obviously,
right?
Okay. So that's where the gateway here is a large 32 millimeter device, then that's a problem.
The only indication to do that is if, because I think the electrophysiologists are going to have great difficulty in crossing this septum in the future to close the atrial appendage.
We're going to wrap this session. Massimo, thank you for a very nice case. Well done. We're going to leave you alone here, and Elkhanan is going to present the second.
Thank you to all the staff here in the room. Thank you. Thank you.
Okay, so as we move along, and I think this is a pediatric workshop, but we're now going to discuss ASD closure in elderly, why and how to do it. I'd like to invite Dr. Baumgartner from Münster, Germany.
Thank you very much.